This trial, KEYNOTE-355, was first presented at ASCO 2020 and has been just recently published in Lancet with Javier Cortez as the first author. And we presented an update of this data with some further analyses at San Antonio this year. KEYNOTE-355 randomized women who had, women or men with newly diagnosed metastatic triple negative breast cancer who had recurred at least 6 months from their last treatment with curative intent to receive chemotherapy with either pembrolizumab or placebo in a 2-to-1 ratio. Patients were stratified based on PD-L1 expression using a system called CPS that uses the 22C3 antibody. And the score for stratification was 1 or more versus less than 1. Chemotherapy options included nab-paclitaxel or paclitaxel, 3 weeks on, 1 week off, or gemcitabine and carboplatin, 2 weeks on, 1 week off. The trial was designed to look at the intent to treat population, and then it was modified before the trial was unblinded to look at 2 different subgroups of CPS, 10 or more or 1 or more, with the primary endpoint being CPS of 10 or more, looking at progression-free survival. The total number of patients who were randomized was 847 patients. And of course, 2-to-1 ratio, more to pembro than to placebo. The data that has previously been presented and now published showed that in patients with a PD-L1 CPS of 10 or more, the progression-free survival was markedly increased by actually 4.1 months from 5.6 to 9.7 months with a hazard ratio of 0.65, and that was highly statistically significant and met the statistical endpoint for significance. If you looked at the patients with a PD-L1 CPS of 1 or more, this represents about 75% of patients in the trial because CPS is a much broader categorization of PD-L1. If you look at SP142 that's used for atezolizumab, the same number of patients you'd only see, you look at all patients, maybe 40% are positive by SP142 with 1% or greater, but with 22C3 it would be 75 or 78%. So they really do measure different parts of the PD-L1 positivity. In the intent to treat, of course, the difference, and in PD-L1 CPS 1 or greater, the difference in PFS was about 2 months, and it wasn't statistically significant. What we also did in this analysis, in addition to the primary endpoints I just mentioned, was to look at the progression-free survival by on-study chemotherapy. This was allowed to be chosen by the investigators, and when we looked at the different chemotherapy groups in CPS 10 or more, all patients had a better outcome with pembrolizumab than with placebo. So that was very encouraging, and the difference in PFS is, I think, clinically important. Even with paclitaxel, the difference in PFS went from 3.6 to 9.6 months. In the nab-paclitaxel, 5.5 to 9.9 months. The difference was the most narrow with gemcitabine and carboplatin, representing about half of the patients. But these patients also generally had taxane-resistant disease and a shorter disease-free interval, and the trial wasn't powered to look at differences between the groups. We looked at response rate, which was increased in patients who received pembrolizumab versus placebo. And again, just like PFS, it tended to be enriched in higher expression of PD-L1, so the CPS of 10 or more versus 1 or more. And then we looked at, there was a higher response independent of which chemotherapy you received, so true of all chemotherapy. And then really striking was the duration of response, which in PD-L1 of CPS of 10 or more went from 7.3 months with placebo to 19.3 months with pembrolizumab. Really quite impressive. So this has told us, in the light of pembrolizumab and chemotherapy receiving accelerated approval by the US FDA in November of 2020, just before San Antonio, that indeed we can use pembrolizumab with an expectation of improved PFS in patients who've relapsed a little bit earlier than what we could with Impassion 130, and that we can use different chemotherapy partners in order to try and improve the progression-free survival and duration of response for patients with metastatic triple-negative breast cancer, as long as their tumor is PD-L1 positive with a CPS of 10 or more.